Hi, everybody. I'm Ashwin.
And I'm Raj.
This is Blood Cancer Talks. This is a podcast exclusively dedicated to hematologic malignancies, where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Today, we are excited to talk about the management of systemic mastocytosis. We have an expert, Dr. Daniel DeAngelo, a professor of medicine at Harvard Medical School and chief of the Division of Leukemia at the Dana Farber Cancer Institute in Boston. Dr. DeAngelo, thank you so much for joining us and thank you for your time. Before we start, can you tell us about yourself and your clinical and research focus for our listeners?
Sure. Thanks, Ashwin, for inviting me. So I'm, as you mentioned, I'm chief of the Division of Leukemia. So I started as a leukemia doctor taking care of patients with acute and chronic leukemias and other bone marrow disorders. Our allergist in the group started with Frank Austin and Jim Aiken when they were at the Brigham, had a series of patients with systemic mastocytosis, and I used to do all their bone marrow examinations. It clearly it developed into a very interesting disease, one that I had not learned about in med school, where I used to see maybe one or two cases a year. Now I see one or two new cases a week. So, it is a rare disease, but a very interesting one, one that I think deserves a lot of attention. So I'm really excited to be here today.
So, do you still review the bone marrow biopsies for patients with heme malignancies?
I
Oh,
do.
wow.
Yeah, I still look at my own slides. I think that it's very useful because it's hard to know. Your pathologists are trying to do their job, but sometimes the samples are good, sometimes they're not so good, and you can see how they're struggling, and it can be very useful. The other thing is sometimes I notice, I've been doing it for 30 years. I notice things that maybe that some of the more junior pathologists may miss, specifically some of the non-mast cell components. And we'll talk about that later, but mastocytosis is, at least in the advanced forms, often associated with another blood disorder. So it can be very important to have another pair of eyes, so to speak.
Fantastic. So, with that, let us jump right in. We'll start with the case, and you can walk us through how would you would approach this case, and then we can discuss all the data. So, we divided into two cases. So, the first case is a 45-year-old female who had a past medical history of anxiety, was referred by primary care physician for persistent fatigue and this diffuse, discrete somewhat pigmented macular rashes in her thighs as well as upper chest, which periodically became pruritic and raised. That's the main reason she was referred to you. And her blood work showed a white count of 7.7, hemoglobin 13.9, and platelets were normal at 316. So preserved blood counts. She had a skin biopsy done for this rash, which showed a mast cell infiltration, and a subsequent workup showed a tryptase level of 34. With the concern of mastocytosis, she also underwent a bone marrow aspiration and biopsy, which showed multiple dense aggregates of atypical round immature mast cells with aberrant CD25 staining, with a total mast cell count around 10 to 15%. Molecular testing also showed presence of KIT D816V mutation. I don't have the variant allele frequency, and I think probably that's something we can talk about. And there is imaging showed no evidence of hepatosplenomegaly. So, in a patient like this who comes to your clinic, Dr. D'Angelo, can you walk us your thought process and diagnosis, as well as now what other diagnostic tests you would like to order to evaluate the patient further, and in terms of also talking about the management down the line?
Yeah, so this is a very classic case that gets referred all the time. And often I'll see the patients referred in from either the allergist or the dermatologist before a bone marrow examination for the concern of systemic mastocytosis. So the patient clearly has cutaneous disease. She has what we call urticaria pigmentosa or pigmented hives. These are lesions that will degranulate when they get activated with an allergen or an exposure to something. Sometimes the patients know what causes them, sometimes they don't. And this flushing or hive-like expression can be really problematic and sometimes even lead to life-threatening anaphylaxis. So patients come into the hematologist from one of four different groups, either because they have an anaphylaxis or to some chemical or after a insect bite, which is bee, wasp, hornet. So we all know about patients or people, I should say, who have mast cell disorders. These are often people with, these very life-threatening bee or wasp stings. They don't know they do at the time, but they do. And so anybody who has a anaphylaxis or a stinging bite really should be evaluated for possible systemic mastocytosis. And so this patient clearly has the lesions and clearly has the symptoms. And so the dermatologist referred to hematology to get a bone marrow exam. Just to separate out a second, children will often have cutaneous mastocytosis. These are often kids with milk allergies or other allergies. They usually get better by the time they hit adolescence and adulthood and seldom convert into systemic disease. The opposite is true for adults, however. Patients with cutaneous disease over the course of time, most will develop systemic disease, but not all. And it behooves the hematologist to make that diagnosis. In the example that you made, the bone marrow examination was done, and it's really classic type of description by the WHO 2022. We all have mast cells. And so the difference between a person with just increased mast cells versus atypical mast cells is, are they forming clusters or aggregates of 15 or more? That separates out an atypical mast cell infiltration from just increased mast cells. So if you had an allergic reaction, you may just have too many mast cells, but they should be loose and in singles. This person has dense aggregates. They're aberrant. They express CD25. Normal mast cells don't. They have atypical or immature features. Again, normal mast cells don't. And then the KIT mutation. All mast cells are driven by KIT, but a mutant form of KIT, which is the D816V in about 90-95% of cases, is really the hallmark. And then the last important WHO minor criteria is a tryptase level. I'll remind the group that there are hereditary forms of alpha tryptasemia, something called HAT, H-A-T. We're all born with two forms of alpha and two forms of beta, but there are people who have an extra copy or even two extra copies of the tryptase gene, and this causes a slightly higher level of baseline tryptase in these patients. They don't all have developed systemic mastocytosis, but there's an increased risk. About 6% of the Caucasian population, that's a huge number, will have hereditary alpha tryptasemia, and these are folks with increased allergies, and about 15% of patients with systemic mastocytosis will have HAT. So again, you can see a higher incidence in these folks. So this is clearly a patient with systemic mastocytosis based on the bone marrow examination, again, either referred from allergy or dermatology, as this patient was, and meets the WHO criteria.
So one question is, you classically mentioned about this bone marrow biopsy findings about dense mast cell aggregates, more than 15, and that's when it raises suspicion for mastocytosis. Let's say, for example, that we don't see that classic findings in the bone marrow biopsy, but the KIT mutation comes back as positive. How would you diagnose a case like that?
Yeah, so if the KIT mutation, so there's major and minor criteria. The major criteria, the aggregates. Sometimes you don't see aggregates. Sometimes you just see an increased tryptase or a KIT mutation. So the diagnosis based on the WHO 2022 is one major and one minor. So aggregates is the major. That's the only major. And the minor would be, atypical or spindle form, CD25 expression, abnormal or tryptase level greater than 20. So not just elevated, it has to be greater than 20 and a mutation. So if we just saw no aggregates and which can happen and a mutation, you'd have to worry that there's at least a clonal process. And if the patient doesn't meet the criteria today, it may very well meet the criteria tomorrow. So if I saw just an two minor, that is, the patient has elevated tryptase and a mutation, by definition, they're clonal because there's a mutation,
Yeah.
then that patient's going to be followed a little bit more closely.
I know you already touched about the WHO classification of systemic mastocytosis, and we also have ICC classification as well. And right now, we are struggling to reconcile the differences between these two classification systems in all the hematologic malignancies. Maybe can you walk us through what are the main differences between the WHO classification and ICC classification for systemic mastocytosis?
The WHO and the ICC are not too far aligned. The difficulty relies in the AHN component. There's some differences in that, but they're not too far aligned. There's some differences and subtle differences in terms of how the tryptase is measured. If you have hereditary alpha tryptasemia, and whether or not you can, in addition to the KIT D816V, other KIT activating mutations have been added to the WHO and not the ICC. So there's some very subtle fine differences, but they're actually relatively well aligned in this particular scenario and not too far off, which is in deference to, as you know, patients with MDS and AML, which can be really a struggle.
Yeah, absolutely. So we briefly talked about KIT D8161V mutation, which is classically seen in almost 95% cases with mastocytosis. Does the variant allele frequency of the mutation also matters in diagnosing as well as treating this particular disease?
Yeah, that's a great question that we don't know much about. So, uh, what I can tell you is that the higher, and it depends on where you're measuring it, right? So if you're measuring it from the bone marrow, you're measuring, and you think about what white cells. So you're measuring the mutant, the variant allele frequency, just to reflect, is the mutant sequence versus all normal sequences. And the mutant sequence is only going to be in the mast cell component. And so in most patients, the mast cells are within the spicules, within the core. So when you're pulling the aspirate, you're getting very few mast cells, with the exception of patients with mast cell leukemia. So in this particular example, this patient is going to have a very low number of mast cells that are contained within the bone marrow aspirate and virtually none in the peripheral blood. So we would expect the allele frequency to be very low. However, we have patients with indolent systemic mastocytosis with varying allele frequencies of 10%, 20%. I even have a patient with 30%. These are patients who tend to have a much higher symptom score. And if you think about it, a varying allele frequency, let's say 20%, that means that the clone size is 40%, right? Because you have one mutant type and one wild type copy in the cell. Yet in the bone marrow aspirate, there may only be 1% mast cells. So it may represent a larger clone in some of the non-mast cell leukocytes than what we really understand. We don't understand that. It's been poorly published. But the higher the KIT allele frequency, just to be specific, the more likely patients are going to have symptomatic mast cell related disease. So more pruritus, more flushing, more GI components, more neurologic symptoms. And these are the patients that are particularly prone to really have significant comorbidities related to their disease. But it's a fascinating question, one that we really need to tease out a little bit better.
Yeah. And you said that the variant frequency correlates very well with the disease burden. Do you monitor that variant frequency while the patient is on treatment, or we have not reached that stage where we use this as a marker of treatment response?
Yeah. So two things. So the variant allele frequency in advanced SM, it reflects the disease burden, that is the number of malignant cells. In ISM, it's not necessarily correlated with the number of mast cells. Remember, there's not that many mast cells in patients with ISM typically, but it correlates with symptoms. So the higher the allele frequency, the more the symptoms. In advanced SM, where patients have organ damage by definition, and you're trying to debulk the disease, having a decline in the variant allele frequency can be very helpful because it's reflective of decreasing the allele burden. I'm sorry, the disease burden by the mast cell compartment, i.e., the bone marrow mast cell numbers, percentages, the tryptase, and the allele frequency is just another measure of that. In ISM, that hasn't been well studied. The Pioneer study didn't show that, and we'll talk about that later, but really didn't look at that yet. That's ongoing studies is trying to correlate the allele burden with symptoms and disease response.
You mentioned already about ISM and advanced SM. Maybe for our listeners, if you would like to break it down in a high level, what is mastocytosis composed of, and how would you divide them?
Yeah, so this is where it gets tricky. We could spend an hour just going over this. Uh,
Yeah.
the pathologist is going to make a diagnosis of systemic mastocytosis. So this is where my pet peeve comes in. And the hematologist is going to say, oh, the patient has systemic mastocytosis. Then what does the patient have? So everything else is clinically based. So the bone marrow's done or a colon biopsy, some tissue biopsy. In this particular patient, known cutaneous disease and has symptoms. So a bone marrow is the easiest source, and the diagnosis of atypical mast cell, making the diagnosis of systemic mastocytosis. But what is the classification? And so Peter Vallant, many years ago with the Mast Cell Society, put together some criteria. There's what are called B findings and C findings. And simplistically, the B findings is just disease burden. So if you have a mast cell component of more than 30%, that's 30% atypical mast cells in the bone marrow, a tryptase of more than 200, very high, hepatomegaly, splenomegaly, not hepatic dysfunction now, hepatomegaly, splenomegaly. These are criteria for a bulky disease. So these are patients with smoldering systemic mastocytosis. Those are called B findings. And some of the new WHO added the allele frequency to that of 10% or higher, but be that as it may. So B for burden. And C findings have been coined. C for need for cytoreduction. And so these are patients where there's so many mast cells, and the mast cells are causing organ dysfunction. So, for example, the mast cells are involving the bone marrow, not just to the point of being there, but to the point that the bone marrow is dysfunctional. So there's cytopenias, there's neutropenia, there's anemia, there's thrombocytopenia, and there's defined definitions. The mast cells are involving the liver, not just so that the liver is enlarged, hepatomegaly, but that the liver is not working well. So there's hepatic dysfunction or hepatopathy. So elevation of liver function tests, or the development of ascites or hepatic portal vein hypertension, for example. There's enough GI involvement that there's malnourishment and hypoalbuminemia. The spleen's involved, not just to the point of splenomegaly, but causing hypersplenism, which is defined as having thrombocytopenia. So true organ dysfunction. And so those patients have a much limited life expectancy as compared to patients without, and therefore they have advanced disease. So C findings, need for cytoreduction, those are patients with advanced systemic mastocytosis. And there's three different subtypes, which I'll get to in a second. The B findings are patients with smoldering, and then patients without any B findings and without any C findings are by definition the most common type, which have indolent systemic mastocytosis. Now, the WHO differs from the ICC now. Again, back to the question you asked, they added a new entity, which is indolent systemic mastocytosis, which is called bone marrow only mastocytosis. Our patients has cutaneous involvement. I don't know that I don't treat those patients any different. They still have ISM, but that's another type of indolent disease. So we have indolent, no B or C findings, smoldering, just B findings, and advanced, which are C findings. Now, the patients with C findings, they come in now three different types. Pure mast cell disorder, which is aggressive systemic mastocytosis, a term I'm not really fond of. Mast cell leukemia, which is different and often gets confused as compared to the acute leukemias that you and I deal with all the time, where we think 20% blasts are acute leukemia. Now, it doesn't care where the blasts are. But in here, mast cell leukemia is more than 20% blasts in the bone marrow aspirate, not the biopsy. So when the aspirate has 20% blasts, that's going to be mast cell leukemia, rare entity, very aggressive. And then about 75% of patients, there's the mastocytosis, but there's also another hematologic neoplasm within the non-mast cell component. And this is called systemic mastocytosis with an associated hematologic neoplasm. Interestingly, accounts for 80%. And so it gets very complicated very quickly. But these are clinical diagnoses. The pathologist is saying there's systemic mastocytosis, but it's up to the clinician to break it down between indolent, smoldering, and advanced, and then break down the advanced into 3 different subtypes. And so this is where I think the academician, the academic center can really do the community or local hematologist some service. So very complicated. I'm sorry.
No, this was fantastic, Dr. DeAngelo. I think you walked us through clearly the different types of mastocytosis, and thank you so much for that.
Before recommending therapy, the next thing we need to do is risk stratify our patients. And there are many risk stratification tools in systemic mastocytosis, like the REMA score, the MARS, or the mutation adjusted risk score for advanced systemic mastocytosis, and the GPSM score, which is the global prognostic score for mastocytosis. Can you give us a high level summary of these risk scores and how you approach these tools in clinical practice?
Yeah, so a lot of these are still in development. I think most of the hematologists that I deal with or the local hematologists are not aware of them. So the REMA score is really a set of tools to determine whether or not a patient with indolent systemic mastocytosis warrants more aggressive therapy. There's other tools. The Pioneer study, which was the first randomized study looking at cytoreduction for patients with systemic mastocytosis, used a symptom score akin to what we use for myelofibrosis, which I think a little bit easier. But the REMA score, has to do with, how high the tryptase is and how many mast cells there are and what the the different symptoms are. And that can help guide a clinician in terms of determining whether a patient needs cytoreduction or not. In my practice, I don't use it that often for patients with ISM. I use a total symptom score that was published by the Pioneer group in the New England Journal of Medicine Evidence, where there's 11 different systems and the patient can grade it 1 to 10. It's very simple. And then I just try to maximize supportive care. I don't know that the REMA score adds much. The other scores that you mentioned, the global prognostic score for mastocytosis tries to differentiate whether a patient has advanced SM or not. And then the MARS score, which I think is probably the most important one of all these, is specific for patients really with systemic mastocytosis and an associated hematologic neoplasm. It's akin to the molecular IPSS that we've now evolved into patients with myelodysplastic syndrome. The limitation in the MARS score is it doesn't account for the number of mutations that we're now seeing. It probably needs to be revalidated, but it does incorporate the presence or absence of some of the more common mutations like RUNX1, SRSF2, ASXL1. These are the 3 most common mutations, and whether a patient has 0, 1, or 3, or 2, I'm sorry, really changes the prognosis of these patients. Now, the MARS score was first developed for patients being treated with midostaurin, and we'll get to therapies later. So as you know, prognostic score, I always teach this with the fellows, the prognostic scores are best implemented with the therapy that was used to derive the score. So we need to revalidate this in the new era with Avapritinib and now bezuclastinib, which is a new kid on the block, if you will, for KIT inhibitors to see if they still have the relevance. In the midostaurin and pre-midostaurin era, the MARS score was very important in terms of predicting survival. Of course, that's the most important thing, survival. We need to recapitulate that data with the newer agents.
Yeah, I know that's very helpful. So next, going to some of the symptom management, systemic mastocytosis can lead to some debilitating symptoms despite targeted therapies. What do you recommend for managing persistent symptoms such as GI discomfort, flushing, or pruritus in patients who are already on max dose of antihistamines, for example?
Yeah, so you're absolutely right. So a lot of patients that I see are not on max dose of supportive care. So the first thing to do is just take a take a step back and make sure that all the I's are dotted, T's are crossed. And so every patient should be on an H1 and H2 blocker. It's surprising, some patients take it once in a while, some patients take it all the time. And there's lots of sedating and non-sedating. I typically focus on the non-sedating. Sedating can has some more cognitive impairment, especially during the day. But the non-sedating ones, and there's not a lot of data that one is better than the other. Some patients swear by one drug over the other drug. Some patients will alternate them, but I make sure that my patients are on both an H1 and H2 blocker. And then I add systematically a leukotriene esterase if they're still having allergies, the GI toxicity, maybe a mast cell stabilizer like cromolyn, although they can be hard to get and a pain. It's a liquid taken 3 to 4 times a day. Sometimes low dose aspirin. Now, aspirin is often listed as a drug you want to avoid, but not everybody's allergic to aspirin, and it can as a prostaglandin blocker, it can really improve the symptoms. A lot of patients, a simple, cheap drug that a lot of people forget. Diet management, if patients are having certain effects, there's a lot of data saying that a low histamine diet is helpful, but the data is very, the amount of histamine that a human being has is far in excess of what you're going to take in with strawberries and other agents. So I tend not to worry about that. I try to co-manage my patients with the allergist and the GI if appropriate. Omalizumab as an anti-IgE stabilizer can also be useful, especially in patients with really profound anaphylaxis or anaphylactoid-like reactions. And no patient, absolutely no patient, should leave your room without an EpiPen prescription. That's, in my opinion, that's malpractice. So when I see that, everybody, you carry an EpiPen, and because you never know when the life-threatening. So when patients are truly maximally supported with best supportive care as best as you can do, and they're still symptomatic, then they need cytoreduction. And this is exactly the patient population that was tested in the Pioneer study. Patients had to be screened. There could be no adjustment in their BSC. Patients had to be on 2 or more drugs. The range was 3 to 9. So these are patients that were on polypharmacy to control their symptoms, and in spite of that, still had symptoms. And you had to qualify by having a score of 26 or higher in order to get on. So not only were they on polypharmacy, but they were still having symptoms. It was interfering with their quality of life. And I've had patients where it says, well, it's not so bad. I went at my wedding, I anaphylacted, I used an EpiPen, I went to the hospital, I went to another party, I anaphylacted, I used my EpiPen. So you're telling me that in 3 months you were in the hospital twice because of an anaphylactic reaction. You're saying it's not so bad. That sounds really bad to me. So you'd be surprised by how symptomatic these patients can be. So in patients where you've maximized best supportive care to the best of your ability and they're still having symptoms, and you can use the symptom score, which I find a little bit more little easier than for example, the REMA score that we talked about previously. And those are the patients I think that cytoreductive therapy, and currently Avapritinib is the only FDA-approved agent, 25 milligrams. Compared to placebo, it had a huge benefit. It's not the perfect drug in terms of resolving all symptoms, but it had a huge improvement in improving symptoms and managing better. And so not only were symptoms reduced, some patients are able to decrease their best supportive care medications. And I think an improvement in quality of life, which of course is what we want.
Yeah, I was going to ask you about the patient-reported outcome instruments next, but I think you kind of alluded to that already, why it is important to measure those in clinical trials. One thing that I wanted to ask is anaphylaxis is a common complication in systemic mastocytosis patients. So other than, as you said, EpiPen, always carrying an EpiPen, what are your other recommendations for managing anaphylaxis risk, especially with nocturnal allergies and idiopathic cases?
Yeah, so that's a great question. This is something where I really work heavily with my allergist here, and the biggest problem I have in patients who are in the community is some of them don't have an allergist that they can work with. But omalizumab, when somebody's having anaphylactic reactions, the addition of an IG stabilizer or amalizumab can be really dramatically changing in terms of really improving quality of life. So that's the one agent that I think is underutilized. It's an infusion. There can be side effects from it, but it's really the agent that I go to. And again, really maximizing those agents. I can tell you that my experience on the Pioneer study is that patients who had a successful cytoreduction and improvement, that their frequency of anaphylactic reactions were markedly improved. So that's really the things that I do in duplicate is omalizumab, and if they're really having symptoms, I will also do the avapritinib. I usually do them concurrently now because I find that reduction of those patients with reactions is going to be helpful. And of course, working with the allergist to try and find, what are the typical things that the patient's allergic to. And you don't always find it. Some of these are or idiopathic. And this is also where I would probably send a patient's peripheral blood for hereditary alpha tryptasemia. It's not going to change the management of the patient, although I'm going to be more hyper alert. Patients with HAT, as I mentioned, already have a higher incidence of systemic mastocytosis. The die is cast. If they have systemic mastocytosis, they have it. It doesn't seem to be any worse or any better than that. But their anaphylactic reactions can be a little bit worse. So if they have had, I'm going to be a little bit more in tune, a little bit more aggressive on that venue. I think that's something that's often not done. Now, it's a send out test. I don't know any institution, academic or otherwise, that's doing it homegrown, but there's several places in the country that it can easily be done. It's just a simple blood test. Most, at least our allergy group, will send it for anybody with an idiopathic anaphylaxis or HAT, especially if there's a family. Well, that's obvious. If there's a family history, so, oh, my sister or my mother also has weird allergies, that's like a red flag. But that kind of can, again, doesn't focus on the management of the SM, but it may help you in terms of managing the anaphylactic type reactions. These are really problematic. Two simple anecdotal cases. I have a patient of mine with advanced SM who also has mast cell activation syndrome, and it's a classic Venn diagram, right? There are patients with mast cell activation syndrome who don't have systemic mastocytosis, and then there's many patients with systemic mastocytosis who don't have mast cell activation syndrome. But my patient had both, and she would have idiopathic anaphylaxis, and who knows what stimulated her, but she was in the ICU on an epinephrine drip for 48 hours, and we couldn't turn the epi drip off because every time you did it, her blood pressure would fall. And it was, again, I keep telling people that these patients can get sick, but when you see it, it's pretty dramatic. And I had another patient who had an anaphylactic reaction to her flu vaccine this year, and she's had flu vaccines every year. But this year she got it a few hours later. She was having shortness of breath. She ended up in the ICU on an epinephrine drip, and that happened about 2 weeks ago. You just have to be hyper vigilant. And these are patients, so when they hit the emergency, yes, this patient is at risk of something severe. It's two anecdotal cases, but we can go on for hours on that.
Yeah, no, it's good to know. I wasn't aware, definitely. Next, I wanted to briefly touch upon osteoporosis, which is prevalent in systemic mastocytosis, especially in indolent cases. I'm curious as to why, the association and what steps can be taken to prevent fractures and bone density loss in these patients, and how should clinicians monitor bone health over time?
Raj, that's a great question. I'm almost embarrassed for not bringing it up to this point. Thank you for asking. That is on the checklist for every hematologist, allergist. Whenever you make a diagnosis of systemic mastocytosis, determination of bone health is right up there. And so patients with mast cell involvement in their marrow, and it's not clear what the mechanism, or if it is clear, I don't know what the mechanism is, but osteoporosis is seen or osteopenia, osteoporosis is seen in about 30% of patients. In fact, it can be the presenting symptom. I've had young men, 30, 40s, who present with compression fractures. And so when you see a patient with compression fracture, obviously you're thinking of an endocrine disorder, but you also got to be thinking about systemic mastocytosis, which obviously brought them to my clinic. So the usual agents, bisphosphonates, denosumab, these are agents that are very useful in trying to improve bone health. But it's very important. Any patient has SM that they get a bone DEXA scan and it gets followed. What's less clear is whether or not mast cell reduction can improve bone health. So the ASH abstracts were released today for 2024. So I'm not embargoed anymore. I can tell you that we have an ASH abstract that we presented this December showing that patients on the advanced SM Avapritinib trial that we followed in the subset of patients that we had serial bone DEXA scans, we saw significant improvements in bone health measured two ways, measured by improvement in the bone DEXA scan, so better bone mineralization, if you will. And then for those patients who had osteosclerosis, we saw reductions of osteosclerosis. So we measured it in two different ways. Now it's a subset of patients, so all that, because not everybody had serial DEXA scans, but I think it's the first really systematic approach to that, and it needs to be studied further in other studies. But it's got to be on the to-do list. Not only do you check the EpiPen script, but you make sure a bone density scan is done and then followed. So thank you for bringing that up. I was amiss for not bringing it up earlier.
Thank you, Dr. DeAngelo, for that. And you briefly touched about in terms of management, about the Pioneer preclinical trial, which led to the FDA approval of Avapritinib for indolent systemic mastocytosis. As you briefly mentioned, there are other treatments as well, as a new kid in the block, Bezuclastinib. Can you maybe briefly talk about the Summit trial in non-advanced systemic mastocytosis?
Yeah, so there's two other KIT inhibitors that are now being explored, and there's other approaches as well. So these are all mirroring the Pioneer study, that is, taking groups of patients with indolent systemic mastocytosis. The Summit trial also includes some patients with smoldering, but no advanced cases. And these are patients on best supportive care, as we've outlined, median of 2, 3 agents. I think the median is 3, but 2 to 9, polypharmacy, still having symptoms. The symptom score, the symptom tool is a little bit different that was used in the Blueprint studies, the Pioneer studies, than the Bezuclastinib or Cogent studies. But the same idea. There's going to be an updated ASH again, looking at the part 1, which is the dose finding study for Bezuclastinib in non-advanced SM. Again, showing really profound reductions in mast cell burden, important, but most importantly, because these patients live forever, right? This is a benign indolent disease. Indolent disease. It's not benign because they have a lot of symptoms, but it seldom progresses to advanced disease. And so the Summit trial really, at least part 1. Now, part 2 is the randomized portion, comparing Bezuclastinib at a fixed dose of 100 milligrams to placebo. And that is expected to meet accrual this calendar year, which means the readout will be the summer of 2025. But part 1 will be presented at ASH in 2024. The other study that was presented in part is the Harbor trial, which is using a drug called elenestinib, which is very similar to Avapritinib, but doesn't have the effect that it doesn't cross the blood-brain barrier. And that's being tested in a similar population than in the Pioneer, again, in a dose-finding study, which will hopefully matriculate into a randomized study. There's a third study that's about to open. It may have opened some places. It's called the Telos study. It's a BTK inhibitor. So it's different. The BTK inhibitor by Telos is an agent that does not decrease the mast cell burden, but it blocks the cytokine cascade, and therefore hopefully will be, well, who knows if it's going to be more effective, but hopefully will be incredibly effective in terms of blocking a lot of the mast cell agents that cause all the cytokine release and all the effects and the symptoms that these patients are experiencing. So that's kind of the field for ISM. We have Avapritinib, FDA approved. We have elenestinib in the Harbor study, Bezuclastinib in the Summit study, and then there's a third Telos study, which is a BTK inhibitor opening up.
With that, I think let's transition to the next part of our discussion, which is the advanced systemic mastocytosis. So I'll start with a case and then maybe we can talk about management of these patients. So the next case is a 70-year-old male with presenting symptoms of weight loss, abdominal pain, and night sweats. Initial workup with imaging revealed splenomegaly. Blood count showed anemia and thrombocytopenia, which ultimately led to the bone marrow biopsy, which revealed aggregates of mast cells accounting for 50% of the total nucleated cells, expressing CD25, CD30, CD123, and CD2, and also had a significant background of trilineage dysplasia. And the myeloid NGS panel showed a presence of KIT D816V mutation, along with the presence of the myeloid mutations of SRSF2 and TET2 mutation. And the serum tryptase showed 200, significantly elevated. So this is clearly a classic case of advanced systemic mastocytosis. So maybe you can talk about, how would you approach a case like this? What are the first line of treatments? And then we can talk about the clinical trials which led to the FDA approval of the medications.
Yeah, so this is a great case, Ashwin. So thanks for presenting this. And this is a very typical case. It's the median age is in the 60s to 70s. These are older patients. These are often patients who had no prior history. I think the difficult things for people to comprehend is that patients either present with ISM, indolent, or they present with advanced. It's only about 1 or 2% that will progress from ISM to advanced. I think that's an important concept. So this patient presented, either to local hematologist because of cytopenias, or maybe to his PCP gastroenterologist because of his organomegaly. But the patient clearly is symptomatic by definition. He has splenomegaly, he has anemia and thrombocytopenia, so needs to be treated. And diagnosis of a systemic mastocytosis was made. So again, whenever a hematologist or clinician sees this, it's important to ask the pathologist or review the slides as we started our discussion, is to make sure what's in the non-mast cell component, because human nature is human nature. You're going to focus on what you think. If 50% of the cells are mastocytosis, you can click the box, patient has systemic mastocytosis. But it's very important to look at the non-mast cell. I know when I started this field with mastocytosis back in the 2000, the pathologists were just signing it out as SM. But 75% of patients with systemic mastocytosis are going to have an associated hematologic neoplasm. And this particular patient has trilineage or multilineage dysplasia. So the underlying diagnosis would be myelodysplastic syndrome. There's no mention of increased blast, so probably a lower risk MDS. Back to the Mars score that we talked about before, the patient has a high-risk mutation, SRSF2. Doesn't have other high-risk mutations, but has one. So this puts him into that intermediate group and warrants therapy. Warrants therapy because he has, splenomegaly, likely symptomatic. He has cytopenias, and so one wants to reduce the mast cell component. So these were exactly the patients that were enrolled on the first study that we tested, which was the midostaurin. There was a midostaurin study that Jason Gottlieb and I did and published. That was a multi-institution small pilot study that showed significant improvement in outcome that led to a larger multi-center study that was published in the New England Journal that led to the approval. This is about 10 years ago now for midostaurin. It's important to remember that midostaurin is a pan-tyrosine kinase inhibitor, 100 milligrams twice a day. And for those of you who take care of leukemia patients, you'll realize that's a high dose, because in FLT3 mutated AML, we use 50 milligrams twice a day because people didn't tolerate 100 milligrams twice a day because of the GI side effects. This is not an easy dose. And so for those of you who use midostaurin, and it's the only agent approved for advanced systemic mastocytosis when the platelets are less than 50. More than 50, we'll talk about the newer agents. I usually get, give me 3 months. We have to figure out a dose, figure out how you do it. I start patients at 100 twice a day. Everybody gets dose reduced, but there is a dose response curve with midostaurin and SM. So, the patients who get 100 twice a day, and then they go down to 25 twice a day, and it doesn't work because it's the wrong dose, right? So you got to work with the patient, work on antiemetics, try and get the patient back up to whatever the highest dose the patient can tolerate, and it takes several months. The important thing when you look at the New England Journal paper is there were no CRs and there were no CRIs. They were all partial remissions or clinical improvement. The drug works, patients live longer, but they don't go into complete remission. So along comes the new, more potent KIT inhibitors, Avapritinib, and the Explorer and Pathfinder studies. And for the first time, we're seeing bona fide complete remissions, bona fide reductions in the allele burden, some even molecularly clear. And that led to an improvement in survival as compared to midostaurin, and even some of the non-approved drugs like cladribine, interferon, which is drugs that we used before midostaurin was approved. So avapritinib, based on the Pathfinder and Explorer, was approved several years ago, even before it was approved for ISM for advanced. But it's 200 milligrams once a day, and it is limited to patients with platelets greater than 50. And the reason for that is because there was some neurocognitive issues and some intracranial bleeding in patients with thrombocytopenia. So that's an important deviation. So this is a patient off a clinical trial that as long as the platelets were greater than 50, and there's no mention that they're not, I would start them on avapritinib. Most patients needed to be after they get cytoreduced, the dose needs to be reduced to 100 milligrams or even 50 milligrams to avoid some of the toxicities. But avapritinib really, for the first time, we were able to see cytoreduction with bona fide complete remissions.
Thank you for walking us through the clinical trials that led to the FDA approval of these medications. Given you briefly touched about the cytoreductive agents, is there any instance where you would still use the cytoreductive agents despite having two FDA-approved TKI inhibitors?
Like cladribine, you mean?
Yeah, cladribine or
Yeah,
interferon.
I think so. Well, this came up this weekend when I was called for a case. We already talked, you mentioned it, Ashwin, 95% of patients have a KIT D816V, and avapritinib is really targeting the mutant form of KIT. It's specific for that. It also hits the wild type, but it hits more potently the mutant type of KIT. And that means that if 95% are mutated, that means that 5 to 10% are not. And avapritinib may not be as effective. We don't know because they're small numbers, of course. You're not powered to look at that. It's still what I would start on every patient. But I had a patient who I got called on this weekend that had a reduction in their disease burden, but rapidly progressed. And so they had tried to use midostaurin. There was some issues. I don't remember what the issues were, but I had recommended cladribine. Cladribine gives very good cytoreduction. I mean, it's a nucleoside analog inhibitor. It's potent, it's aggressive. You don't see CRs, but you can see good cytoreduction, which may allow you then to initiate a lower dose of drug like midostaurin, which is a pan-tyrosine kinase inhibitor, to try and have some stability in order to, if a patient's of age appropriate and disease appropriate, get them to transplant. But I've used cladribine as a bridge. It's not, you can only give a cycle or two, right? Because it's very aggressive therapy. But if you need a cytoreduce quickly, that's the drug. And I mostly will use it in patients that don't respond, and those are often patients with wild type KIT.
Okay, got it. When you're initiating a patient with avapritinib, what are some of the adverse events you discuss with the patient?
Yeah, so it's like CML all over again, right? So you see these agents that are KIT inhibitors, so they can be myelosuppressive, so you can see some cytopenias. You can see some peripheral edema, just like we could with the imatinib and other agents. They're not, there's tricks of the trade. You can get through that. But the ones to avoid are obviously the intracranial hemorrhages, which we were able to abrogate that. So we saw them in the Explorer study, which was a phase 1. We had no limitations early on in platelet count. And then we amended the study, and the Pathfinder only included patients of platelets greater than 50. And for all intents and purposes, we really didn't see much much intracranial hemorrhages as we did. And most of them were very small subdurals, and we were screening patients. So that's one thing I would worry about. And then the other one is just cognitive defect. Remember, this does cross the blood-brain barrier. So patients get like chemo brain. Where's the keys? I put the keys down, I can't find the keys. Or if you're a math person trying to do all the calculations, you may stumble across that. Usually responds very nicely to a clinical hold of the drug, where you hold it for a week and then restart it at a lower dose. If they were at 200, going to 100, and the cognitive side effects really go away very, very, very quickly. So those are the two things I tell the patient to worry about: sudden headache, change in neurostatus, and then the cognitive thing. And the other things are, as I mentioned to you, are mild, which is the edema, periorbital edema, peripheral edema, and then the cytopenias that you're going to follow when you check the labs, and so on and so forth.
With Avapritinib being approved for the frontline therapy, are there any patient groups you would still choose midostaurin over Avapritinib?
Only, yes. I mean, the one that's very clear, as I prefaced, are the patients with platelets less than 50.
50.
That's
Okay.
really the only group where avapritinib is not indicated. So now if the platelets are close, I have a patient who is having a suboptimal response on midostaurin. Platelets are in the 40s, so I'm giving them TPO mimetic agent to try and get the platelets up, so I can hopefully get them transitioned to avapritinib. I think avapritinib, as I've alluded to, is a more active drug. There's never going to be a head-to-head comparison. We do have a abstracted ASH, again, not embargoed anymore, released today, where we were looking at real-world evidence of midostaurin cladribine compared to avapritinib in patients on the Explorer and Pathfinder, showing an improved response and duration of response and survival. So I think the avapritinib is just better because it's really causing more profound cytoreduction. But if your platelets are, below 50, it's not a safe drug to administer. So that would be the one I would do. And then patients without a KIT D816V mutation, it's possible that they may not respond as well. I'll still start avapritinib, but I'll have midostaurin in my back pocket.
Got it. Now the new drug which is creating quite a splash is bezuclastinib, which is a selective TKI and targeting D816V mutation. How does this drug differ from avapritinib or midostaurin? Is it the selectivity that's the difference, or the side effect profile?
Yeah, so we talked about it briefly in the Summit trial. It's being tested in patients with non-advanced SM, both indolent and smoldering. But in the Apex trial, it's being tested in patients with advanced systemic mastocytosis. There was a dose finding part 1 that will also be reported at ASH in 2024. The part 2 is ongoing and enrolling. This is more of a registrational, where all patients are being treated at a dose of 150 milligrams of bezuclastinib a day, and then assessed. It's hard to compare. The trial's still going. Based on the part 1 data, we've seen very rapid cytoreductions in terms of the mast cell disease burden. True CRs have been noted. What we haven't seen is, in the side effect profile, any neurologic effects. This drug does not cross the blood-brain barrier. Therefore, we haven't seen any cognitive issues. We haven't seen any intracranial bleeding issues. We have seen some cytopenias and some, other issues that we often see with kinases, but none of the stuff that we saw with avapritinib. So we'll have to see as the data matures. It's still early in the game, but it seems to be, well, it's clearly a very active drug against in the advanced SM world. So we're very excited about it.
One thing I interestingly noticed that one of the adverse events bezuclastinib causes is change in hair color.
Oh, yeah, but that's an on-target effect. So I think what people tend to forget is wild-type KIT, normal KIT, causes melanin deposition. And so when you get the dose high enough, this is a nice pharmacokinetic. So you can, in the Summit trial, you could tell who was on drug and who wasn't, because if their hair turned white, and I don't mean the white like you see in me, which is just from natural aging, I mean completely white. It's because you're hitting the normal melanocyte deposition in the hair follicles by inhibiting normal wild type KIT. And so as you're able to push the dose, you see that. Now, we saw that in the Explorer and Pathfinder studies at the 200 and higher dose. And as you lower the dose, then you can see, the normal hair color come back. And so, it's kind of a thermometer of how much drug is in. It is listed as a side effect because it's an adverse event. The hair wasn't white and now it's white. But I remind my patients that's a good thing because that means you're taking the drug. That's funny.
That's a
That's
good.
so funny that you mentioned this.
It's a very good point.
Yeah.
So one other patient group I actually very much struggle in the clinic, which are the majority of the patients, is the systemic mastocytosis with associated hematologic neoplasm. Um, how to approach these patient group? They are very tough to treat because sometimes they have both the mastocytosis active as well as the associated hematologic neoplasm, especially when it's something like chronic myelomonocytic leukemia. I think these are very tough to approach, and all the clinical trials, they do not use any other agents apart from the TKI. So, how would you treat in a patient like that?
Yeah, so you nailed it. You nailed it for the question. So this is the struggle. I think this is the one unknown thing. So I would remind you, as you pointed out, that the midostaurin study, remember, 70%, 75% of patients on the midostaurin study, Explorer study, and the Pathfinder study all had SMHN. And shockingly, the same on the APEX study with bezuclastinib. So this is the most common component of advanced SM. And the patients who were enrolled on these historical studies, including the current APEX study, were patients with low risk AHN. That is, the AHN did not require treatment. So you couldn't have patients if they had CMML or MDS, like the patient that you mentioned, they had to have lower risk disease. They couldn't have higher risk disease that you would initiate a hypomethylating agent, for example. So we don't know what's the best approach for those patients with SM, AHN, where the AHN component is higher risk. Uh, the APEX study was amended recently to include a rollover, so patients could get bezuclastinib, and then if the AHN progressed, you could add on a hypomethylating agent, in this case azacitidine, or if they presented, you could start them with the combination. So
Okay.
there's no data yet.
Okay.
There's only been a handful of patients, and that data will not be presented yet. So that's just a recent amendment. The Azure study with elenestinib also has a future arm that will include that. But this is the unclear, unmet need. I can remind you of an abstract from 3 years ago, I believe, at ASH. The paper has not been published yet, from Mike Deininger. And he looked at the 14 patients who progressed on the Explorer study. And I think this is very informative. Of the 14 patients, there were 2 patients that progressed in the mast cell component, and both of those patients had mast cell leukemia. Not surprising. The
Mhm.
other 12 all progressed in the AHN, typically to advanced CMML or MDS
Mhm.
or AML. And so this is the big issue. And so how I treat patients with SM, AHN at lower risk, which were the patients that were studied, is if they have a lot of molecular features or they're showing the acquisition of new molecular abnormalities on their next generation sequencing or NGS platform, I'll transition those patients to transplant. Celeste Houston published in JCO a few years ago the transplant data, and the SM-AHN did the best. But you need to control the SM component because there seems to be a limited graft versus mast cell effect. And of course, we know there's a good graft versus myeloid disease
Mhm.
effect. That's why we transplant the MDS patients. So I get their mast cell burden as low as I can, and then I send them to transplant. If they have disease progression in the AHN component, historically we had to take those patients off study, treat their AHN, and then transplant them, and that's still what I do. Obviously, I'm interested in the amended form of the Apex and the Azure to try and see whether there's a way to combination TKI plus. But right now, that's on clinical investigation. But you're absolutely right. This is the biggest issue, and you have to pay attention to both components because as the mast cell component is getting better, if the AHN component gets worse, these are the patients that you need to treat and send to transplant if they're appropriate age.
And thank you, Dr. DeAngelo.
I think it's a good segue to talk about allogeneic transplant if in systemic mastocytosis. So, with improvements in targeted therapy over the past years, do you think we are moving closer to achieving like a sustained remission or even cure for certain systemic mastocytosis subtypes? And what role do you think allogeneic stem cell transplant might still play in the future of SM?
Yeah, so I think as I alluded in the last question that Ashwin said is, I think it's more directed, at least right now, towards the AHN component. At least that's been my experience. I think when I've been forced to transplant patients who still had a significant SM component, I've had to restart the KIT inhibitor at post-transplant. I have a patient right now where the CMML was progressing. We treated that, got him to transplant, but not shockingly, after transplant, the SM is back, and so now we're aggressively treating his SM, even though his AHN seems to be in remission. These are cases I struggle with all the time. Patients, especially young patients, especially patients of appropriate without comorbidities or organ dysfunction, transplantation is really the curative intent. It's a big treatment for patients with low risk AHN. So it's the same thing. Corey Cutler and John Korath published years ago, at least in MDS, that
Yes.
the lower risk patients you gain life years by delaying transplant, and the higher risk patients you gain life years by transplanting earlier. I don't think that's any different with this particular disease. Again, close attention to both components. I will treat the SM down to remission if I can, and now we have finally good drugs to do it. And then I focus on the AHN. But I will, when I evaluate patients in terms of their marrow, I'm always re-looking at their next generation sequencing to see if I have clonal evolution. And when you see clonal evolution, it's the time to move. I saw a patient in consultation this summer where under the eyes you can see the patient's SM was in remission, but he had a marrow and then another marrow, and there was clear clonal evolution. Yet the patient, wasn't in transplant, and then sure enough, he converted to leukemia. And so, which is unfortunate. I think the cat was out of the bag. So but these are things that we have to address, and two diseases that are somewhat tied, but it does become tricky.
Yeah, this was a fantastic discussion, Dr. DeAngelo. Thank you so much for this. I think you worked on all the complicated nuances with the management of mastocytosis. We truly appreciate all the clinical tidbits as well. And we look forward to having you again on our podcast in the future.
Thank you so much. Be
Thank you
safe.
very much.
Well.